You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or, Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for July 21st, 2023. This week, let's do some listener feedback, conduction system pacing, eating fish versus fish pills, exercise, and an RCT in the nutrition diet space. Okay, some listener feedback. I received from a listener a copy of a review sent by the American College of Cardiology to its members. This was a review of the Monitor HF trial. It came by email. Monitor HF, to remind you, was a small RCT of the CardioMEMS guided management versus standard of care in patients with heart failure. Its primary endpoint was quality of life as measured by the KCCQ, and it favored the CardioMEMS arm. The trial also reported fewer heart failure hospitalizations, but the study had only a fraction of the numbers of the previous trials, say GUIDE-HF, and it was not powered for clinical outcomes. I've done full coverage of the Monitor HF on the June 2nd show. It's literally one of the most difficult studies I have reviewed in a long time. This was an industry-sponsored trial without blinding. Unlike GUIDE-HF, the Monitor HF trial randomized two groups, and both groups knew their treatment assignment. One group knew that they got a fancy monitor, and the other group knew that they did not. And then the authors measured a subjective outcome. Of course, the lack of blinding could also influence the clinician's decision to admit a patient for heart failure, so it's also important in the secondary outcomes. Now, despite the fatal flaw of lack of blinding, Lancet allowed them to make strong conclusions, and Lancet assigned the editorial to an academic with strong financial ties to the maker of CardioMEMS. That editorial mentioned the blinding issue, but then spent 7 other paragraphs praising the device and its role in the management of heart failure. The email that came from ACC, which also takes funding from industry, had as its interpretation these words, quote, "The Monitor HF trial is the first study to demonstrate improved quality of life and functional status associated with the remote invasive hemodynamic monitoring using the CardioMEMS system. CardioMEMS group also experienced fewer heart failure hospitalization, an association that was previously observed in both the Champion and the pre-COVID analysis of the GUIDE-HF trials. As the overall GUIDE-HF analysis yielded a neutral result, the current American heart failure guidelines assign remote cardiac monitoring a Class 2B recommendation. The current findings from Monitor HF provide clinical and patient-centered outcomes data to support the utility of the CardioMEMS system in the management of Class 3 heart failure, even in the setting of high rates of optimal GDMT." And then they go on. They say, this is the ACC, furthermore, these are the first data studying the device in the European healthcare system, as remote monitoring requires sustainable infrastructure to coordinate patient care outside the immediate clinic setting. Additional data across different healthcare delivery systems provide important information. Now, they do say, unlike Champion and GUIDE-HF, this was an open-label study with no sham implantation in control patients. However, the positive results observed in both the heart failure hospitalization and objective markers of congestion reduced the likelihood of a clinically significant placebo effect in the treatment arm. Now, this is from ACC, my friends. I say no, no, double no. This breaks the rules of basic science. This mailer from ACC bothers me so much. Not so much because another low-value device will get expanded use because overuse of low-value devices is rampant in cardiology. But I am sad for the scientific enterprise, right? Monitor HF was a totally flawed study from its design. Subjective endpoints without blinding are just about worthless, and the investigators knew this, of course. The emphasis on heart failure hospitalizations in that study was nowhere near enough power, and no blinding is also essentially worthless, and the investigators know that too. The Lancet editors knew all of this. The peer reviewers must have known it, and there it is in Lancet, a positive accompanying editorial of a broken trial from an author with a serious conflict of interest. And to make matters worse now, our own American College of Cardiology sends a glowing interpretation, glossing over the central flaw to its many members. The Monitor HF story is so brazen, it just makes me really sad. Please help me, listeners. Tell me I'm wrong about this. Make me feel better. The second bit of feedback comes from my friend and former partner, the skeptical cardiologist, Anthony Pearson. He sent me a tweet from the American Heart Association, AHA, where they are promoting a 6-part podcast called Close the Space, and space is in capital letters, and it's for the abbreviation Secondary Prevention of Atherosclerotic Cardiovascular Disease Care Education Summit. Now, Dr. Pearson writes, sure enough, through a collaboration with Novartis, the American Heart Association has created this podcast series called Atherosclerotic Cardiovascular Disease Perspectives. Now, you all will never guess what drug Novartis makes. Yes, last week I covered the FDA's expansion of the indication of the small interfering RNA agent inclisiran. The thing is that the inclisiran approval is based primarily on its ability to lower LDL cholesterol. There has yet to be a true cardiovascular outcomes trial, and I know the drug will surely be costly. The problematic area is the collaboration here of professional societies and industry. I don't like it. If the outcome trial with inclisiran is positive, I will cover it as a positive trial. But the fact that these professional societies, American Heart, ACC, ESC, HRS, the heart failure societies, let themselves be advertising platforms is problematic. Maybe I am wrong. Let me know again. To me, professional societies ought to be advocates of neutral, critical appraisal. How can you do that with these sorts of dualities of interest? All right, first topic today is conduction system pacing. Now, I know that electrophysiology can be specialized, but one area that the medical field should know about is the utter transformation that's happening in cardiac pacing. In hospitals that have an electrophysiologist doctor implanting devices, there are now strong movements to place the RV pacing lead into the conduction system in the septum of the heart. That doesn't sound super interesting, I know. I mean, why would a general cardiologist or general internist or regular listener of this podcast care about where we are putting pacing leads into the heart? What makes this change important to all is how it pertains to evidence-based practice. And the use of evidence is a core tenet of this podcast. So let's talk about the most recent conduction system pacing versus RV pacing study that was published in JACC EP, which, by the way, is becoming an excellent journal. This was a 2-center study done in Singapore of patients who had pacemakers implanted. It was not randomized. One group got typical RV pacing leads, and the other group got either His bundle pacing or left bundle branch area pacing, basically conduction system pacing. The primary composite outcome was heart failure hospitalizations, upgrade to BiV pacing, or death, so a composite of those three. And the study favored conduction system pacing by a lot. I'm not even going to tell you the numbers because this is too flawed of an analysis to draw any conclusions from. Why? Because of this single sentence in the methods section. Always, my friends, go to the methods section. Quote, "The decision to choose between conduction system pacing and RV pacing was based on the operator's personal preference." Now, my comments, as many of you know, I am a conduction system pacing evangelist. It's like religion. Left bundle branch area pacing delivers these superb pacing parameters, low thresholds, good R waves, etc. as well as those gorgeously narrow QRS complexes. You can pace the ventricle without causing the dyssynchrony that comes with normal RV pacing, and if that avoids the 10 to 20% chance of pacing-induced cardiomyopathy. But the skeptics of conduction system pacing are spot on. We have scant data to support this. The literature is full of studies like the one I just told you about in JACC-EP. They are all unreliable. This is not the way to prove a technique works. What's more, you can add up all the observational studies that favor conduction system pacing versus RV pacing, and even taken together, they add up to unreliable evidence. Here, I want to remind you of a famous example. This is Deborah Grady's meta-analysis in 1992 of hormone replacement therapy in postmenopausal women. This was a meta-analysis of 30 observational studies, and nearly all of them showed that women who took hormone replacement therapy had better cardiovascular outcomes. This led to causal language and that we should use hormone replacement therapy to prevent cardiovascular outcomes. Then, boom, one RCT, Women's Health Initiative, overturned all of them and showed that we're probably causing harm. So the point is that you can add up all of these observational studies. They may show the same thing, but they could all have a systemic bias. And that's the thing about non-random comparisons. When a clinician chooses a therapy, not randomization, you cannot exclude the problem of confounding and selection bias. And the size of the observational study cannot negate the systemic bias. You could have 800, 8,000, or 80,000 patients, and it doesn't matter. It could still be biased. Now, fortunately, conduction system pacing, which is one of the biggest things in all of electrophysiology right now, is going to be tested in RCT form in both the U.S. and Europe, and we will know. Now, one caveat here, though, while non-random observational data can be terrible for making causal inference between two treatments, observational data, say registries, can help provide information on things like procedural complications and temporal patterns of how treatments are being used over time. The mandatory STS registry of aortic valve replacements is a shining example of a good use of observational data. All right, next topic, fish oil. I, like you too, see a lot of patients taking fish oil supplements. I call them fish pills. Now, some are supplements, some are prescription strength, but they are simply just fish pills. The idea is that fish is good for you, right? Because of the observational data, say, from the Inuit in Greenland, who have a high dietary intake of marine omega-3 fatty acids and a low incidence of vascular disease. But it's hard to eat that many fish, and then there is the problem of mercury intake with high fish intake. And there have been a number of large cardiovascular outcomes trials with different formulations of fish oil supplements. And other than the icosapent ethyl, the Reducit trial, most of these large trials are null. Now, Reducit is challenging to interpret because the mineral oil placebo increased lipid levels in that trial. Now, here's the thing. At least 3 of these cardiovascular outcome trials have found this peculiar but strong signal of increased risk of AF, atrial fibrillation. A large meta-analysis led by the group of Christine Albert, is published in Circulation, and I'll link to it, has found that the use of marine fatty acid supplements was associated with an increased risk of AFib. This was 3,000 patients, and the hazard ratio was a 25% higher risk of AFib. And when they did meta-regression, they found that the risk of AFib was dose-dependent. Higher the dose of the fish oil supplement, the greater the risk. Now you ask, why would fish oil supplements increase AFib? And the answer is that no one knows. Why did the VITAL trial, which was done in patients without cardiovascular disease, not find a higher AF signal with fish oil supplementation? All this is a bit of a mystery. And I've been in the habit, though, of telling patients with AFib to stop taking their fish pills. Well, now a large group of eminent authors have published in JACC a very large observational study that explored the AF risk and fish oil. The first author is Frank Huon. This was a very big effort. They used 17 prospective studies that had data on the actual levels of omega-3 fatty acid concentrations in both blood and adipose tissue. I will surely oversimplify their methods, but basically, very basically, they had the number of AFib episodes in these studies, and they then correlated levels of the different omega-3 fatty acids with the incidence of AFib, and of course, with statistical adjustments done. And then they tried to harmonize the data across studies because all of these prospective studies were so different. They found provocative results, and unlike the randomized controlled trials, which have shown a higher AFib risk, they noted, A, that circulating EPA levels in the blood or adipose tissue was not significantly associated with AFib, and B, higher DHA, EPA plus DHA, and DPA levels were actually associated with lower AFib risk. And the results were overall consistent by lipid compartment and across pre-specified subgroups, including those patients with elevated cardiovascular risk status. This is interesting, isn't it? How do we reconcile the higher risk of AFib in trials of prescription-strength fish oil versus these observational findings? Now, the first thing that I hope comes to your mind is that observational studies have a risk of confounding. These are, of course, non-random comparisons. But in this case, the authors have levels of marine fatty acids, and that may mitigate the bias concerns somewhat, I think. But the levels also explain the discrepant results, I think. In this observational study, the levels of marine fatty acids were much lower than those seen in the trials. Both the authors and the editorialists explain that the levels in these prospective studies reflect habitual fish intake rather than high-dose supplementation. So the main message, therefore, may confirm what I've been saying on this podcast and in my clinic for years: eat fish, not fish pills. And I think perhaps the larger message is that prevention of heart disease is never going to be about one thing, because humans are not cars. Like, you can't just fix one thing. A good diet is always going to be important. A lower LDL is important. Not smoking is very important. Good blood pressure and normal glycemia too, and exercise, and stress, and sleep, and lower inflammation, and of course, good luck. That's why the notion to promote one pill, one drug, one diet is always going to lead to incremental advances. If you want to truly impact heart disease, it requires a change, I think, in societal norms. And I'm afraid we're going in the wrong direction here in the U.S. A little memory popped into my head. The ESC meeting is going to be in Amsterdam next month. The last time I was there at ESC, I watched herds of kids riding their bikes to school. That seems like a good start to a lifelong lower risk of vascular disease. All right, exercise is the next topic. One of the things about this podcast is that I try to give appraisal free of bias. I am proud of my lack of industry conflicts, but one area that I have clear bias is in exercise. I am addicted to endurance exercise. I'm like that rat who must run on the wheel every day. Last week, an exercise study made the rounds on both the legacy media and social media. 98 news outlets covered the JAMA study with the title, quote, "Accelerometer-derived weekend warrior physical activity and incident cardiovascular disease." Now, before I read a single word of this study, I began it as a skeptic. Now, putting weekend warrior in the title just seemed like too much trying for attention. The Harvard team, first author Sean Kershid, used the UK Biobank cohort study to compare the association of moderate to vigorous physical activity that was achieved over 1 to 2 days, so-called weekend warrior, versus moderate to vigorous physical activity spread more evenly throughout the week. And they compared those two types of exercise with the risk of having cardiovascular events. Now, the exposure, therefore, studied 3 patterns of physical activity. The active weekend warrior, which was greater than 2.5 hours in 1 to 2 days. The active regular exerciser, who spreads that 2.5 hours over the week more evenly. And, of course, the control group is inactive persons. The biobank data had accelerometer-derived data, which is, of course, better than self-reported physical activity. They had nearly 90,000 people. These were 62-year-olds, adults, half of them female. About 42% were weekend warriors, 24% regular exercisers, and 33% in the active group. And then, of course, after these three groups, they had the statistical adjustments. And both activity patterns were similarly associated with a lower risk of AFib, lower risk of MI, lower risk of heart failure and stroke, and the hazard ratios were all statistically significant and similar. So physical activity concentrated within 1 to 2 days was associated with a similarly lower risk of cardiovascular outcomes to more evenly distributed activity. The manuscript here was impressively short. The editorial was massively long, but I can make this simple. Weekend warrior exercise is better than no exercise, but I think this is a bad idea to promote. For many people, this is my opinion, because physical activity is not just for reducing AFib and MI and stroke and heart failure. Overall health, good health, transcends just some cardiovascular outcomes. My idea, and what I tell patients, is that a little exercise every day is like a health pill, one that is way better than a fish pill, for instance. Every day I'm talking about, todos los días. I say you should do something for 15 minutes, 20 minutes, 30 minutes, a walk, an exercise bike, a swim, whatever. Golf doesn't count. Something sustained every day. I think the mistake people make is thinking that exercise has to be training. I'm not talking about training. It's just movement that's sustained for some period of time. I tell patients if they want to build up and do more exercise, fine, but do something every day. When I grew up, my maternal grandfather lived with us for many years in our dining room. He did a little exercise every day. He almost made it to 100. Even when he couldn't walk well, he did daily exercises in his bed or chair. I recall him doing these exercises once when he was in the ICU. You want exercise to be ingrained into life, like the Dutch kids riding to school. Now, I don't doubt that a Harvard group studying a healthy volunteer group in the UK Biobank can show that weekend warriors have similar cardiovascular outcomes than regular exercisers. That's fine, but that's only one part of exercise's role in health. All right, final topic today is on diet. New England Journal Medicine has published big RCT comparing diets. Yes, an RCT in the nutrition space. That, in and of itself, is worthy of celebration, since so much of nutrition science is marred by worthless observational studies of blueberries and coffee and whatever else. This was the Mediterranean dash intervention for neurodegenerative delay, aka the MIND diet, M-I-N-D diet. Now, MIND is a hybrid of the Mediterranean diet and the DASH diet. DASH is dietary approaches to stop hypertension. This included modifications to include foods that have been possibly associated with a decreased risk of dementia. The MIND diet emphasizes consumption of plant-based foods, including green leafy vegetables, nuts, berries, fish, and olive oil. The diet limits the intake of foods with high levels of saturated fat and sugar, such as red and processed meat, butter and margarine, whole-fat cheese, pastries and sweets, and fried foods, and I'm sure Cheez-Its. The patients were 70-year-old patients, mostly female, who had no cognitive decline at baseline. They did have a positive family history of dementia, an elevated BMI, and a poor diet that was assessed by a questionnaire. The trial tested the MIND diet with calorie restriction versus a control diet with mild calorie restriction, and the trial went for 3 years. The primary endpoint was the change from baseline in a cognition score. Secondary outcomes were brain-derived MRI measures. The trial was null. Both groups improved similarly in global cognition scores, and the MRIs also looked the same. So my comments. I present this to you because this is the way forward to know things. Observational studies looking at foods that are putatively associated with better cognition are all going to be hopelessly confounded, because the people who eat nuts and berries and organic stuff are surely different in many ways than people who don't eat these kinds of foods, and you cannot control for all those variables. Now, you can criticize the study because it's hard to know how much people adhere to the diet. You could say that the control arm would be motivated by being in a study and they may not be representative, which would bias to the null. But I think the main problem in this study and in all trials of diet and lifestyle is that it's so limited in time. I mean, the MIND diet went for 3 years. But surely the prevention of dementia, if it can be prevented by lifestyle at all, is greater than 3 years. It's got to be about a lifetime, like those Dutch kids riding their bikes to school. Anyways, I say congratulations to the authors. Congratulations to the New England Journal of Medicine for publishing an RCT that had null results. This allows me to close this podcast on a positive note. And that is it for This Week in Cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time to give us a rating. Even those little tiny 1-sentence, 2-sentence reviews go a long way to helping others find us. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.